Good morning, everyone. Welcome to the School of Nursing, Midwifery and Health Systems, UCD. My name is Denise McGuiness, and I'm a lecturer in midwifery here at UCD. I'm delighted to facilitate this webinar today with my colleague, Dr. Gillian Paul, a lecturer, assistant professor in the school. Thank you to each and every one of you for taking the time this morning from your busy clinical roles to celebrate National Breastfeeding Week at UCD in conjunction with HSE My Child. A special thank you to our speakers for sharing their knowledge and expertise with us today. The webinar will be approximately 90 minutes duration. During the webinar, all attendees will be placed on mute. If you have a question during the webinar, please use the question and answer window at the bottom of your screen. To access the question and answer section, move your cursor to the bottom of the screen and locate the question and answer icon. Click and type away with your questions. My colleague, Dr. Denise O'Brien, will facilitate question and answers following each speaker today. This webinar is recorded. You will have the opportunity to listen to the recording after 5 days from the Nursing Midwifery Health System YouTube channel. I'm wondering if the Lord Mayor Hazel Chu is with us yet. Lord Mayor, are you with us? Okay. The Lord Mayor mentioned she may be a few minutes late. So in that case, I'd like to introduce you to our professor here at the school, Professor Gerard Feely, Dean of Nursing and Head of School, who will open the webinar. And then when Hazel Chu, our Lord Mayor, joins us, Gerard will introduce Lord Mayor Hazel Chu to us all today. So it's my pleasure now to invite Professor Gerard Feely, who is Dean of Nursing and Head of School, to officially open our webinar.
Thank you, Denise. Good morning, colleagues, students, healthcare professionals, and members of the public. I bid you a warm welcome to this webinar to mark National Breastfeeding Week 2020. I want to firstly thank my colleagues, Denise McGuiness, whom you just heard speaking, and also Dr. Gillian Paul for hosting this online event. And also, I want to thank Justin Dawson, who's providing the technical support and who's making sure that we're all online and we stay online in this virtual webinar. I also wish to thank all of those of you who have kindly given your time to speak at this morning's webinar. And in her absence, I welcome Lord Mayor of Dublin, Ms. Hazel Chu, who I believe will be joining us presently. I'm just checking there. Yeah, okay. So as a university that educates healthcare professionals, including midwives, public health nurses, doctors, and nutritionists, we teach that breastfeeding is a natural process. And in my school, we provide our midwifery students, public health nursing students, and students of other nursing programs with the most up-to-date research evidence concerning breastfeeding, including breastfeeding rates and the benefits of breastfeeding that we know impact on health well beyond the early months and years of life, including reducing childhood obesity and reducing chronic diseases later on in the child's life. As a university, we also support and promote national policy on breastfeeding. We also conduct research that continues to inform that policy. And you will hear reference to some of that research during this webinar. And while breastfeeding rates are increasing in Ireland, breastfeeding rates in Ireland remain lower than our other comparable developed countries like the USA, the UK, and Australia. And our role at UCD is to educate our midwives, public health nurses, and other healthcare professionals, including doctors and nutritionists, on breastfeeding. And these in turn educate and support and empower mothers and their families and educate the general public on the benefits of breastfeeding. So it is my great pleasure now to launch today's webinar and to hopefully meet Lord Mayor of Dublin, Ms. Hazel Chu, presently. So thank you very much, who will say some opening remarks also. So back over to you, Denise, and thank you very much.
Thank you, Gerard, for that lovely introduction. And we'll go ahead with our first speaker. Our first speaker is Dr. Anne Doolan. And thank you for joining us today. Dr. Anne Doolan is a consultant neonatologist at the Coombe Women and Infants University Hospital. Children's Health Ireland in Cromlin, the Midland Regional Hospital Portlaoise, and she's an assistant clinical professor in UCD. And Anne is also an international board certified lactation consultant. Anne, you're very welcome to UCD today, and your presentation will be in relation to tongue tie. Thank you, Anne.
Good morning, everybody. Thanks so much for your kind introduction. It's great to meet people, albeit virtually. And I'm delighted to share a little bit of what I know about tongue tie. I will hold my hands up and say none of us know everything about it yet. There's a whole load of research still to be done on the topic. And I think we all need to keep an open mind and to change our practice according to best international guidelines. So for the talk, I'm going to talk a little bit about what is tongue tie, how common is it, so what's the incidence of tongue tie, what kind of tools that we use to assess tongue tie, how we treat it, and how important lactation support and breastfeeding support is in supporting these dyads. I like to keep things really simple. I'm a scientist, but I also like when things are very easy to understand. And even if you give up now and go and get a cup of tea and wait for the Lord Mayor to reappear shortly, I'll tell you what I'd like you to take from this talk now, so that if you want to switch off for a while, you can. I think something that I've learned while doing the tongue tie assessment clinic in the Coombe for almost 2 years now, it's not so much about how the tongue looks, it's about how it works. And more I understand that it's not just a visual assessment that's important. I think after listening to the media yesterday about maternity services in Ireland, I think it's taught us all that listening is so important in our jobs and what we do. Listening to the parents, listening to the parent who's breastfeeding, listening to the mum, listening to what's going on for her is so crucially important. And so much can be gained from the history and from watching a baby feed. Is there something else going on? So in the past 2 years, people have told me personal circumstances that are very much influencing what's going on for their breastfeeding journey. We've had babies diagnosed with severe anemia. We've had babies diagnosed with other neurological abnormalities. So involvement of the multidisciplinary team in assessment of tongue tie is crucially important. And the most important treatment of tongue tie is lactation support. So whether or not a baby does have a frenotomy, that the most important thing is that the mom and baby are supported in their feeding journey. So what is tongue tie? It's often called ankyloglossia in the more medical literature. It's a piece of tissue that's visible underneath the tongue. And one Swedish group in 2015 published a paper that looked at 200 babies, and 199 of them had some kind of tissue visible under the tongue. So a frenulum is a normal phenomenon. And in their group, they actually found no correlation between the type of frenulum and breastfeeding difficulties. In our practice, if the lingual frenulum, so if that piece of string underneath the tongue is short or tight or thick, it's called a tongue tie. And a tongue tie can cause restricted mobility and cause feeding issues. In the assessment tools we use, they can be described either anatomically, so literally how the tongue looks, or functionally, so how the tongue works, or a combination of both. And we'll come on to those assessment tools in a minute. One of the problems with the science around tongue tie is there's a lack of a universally accepted definition of tongue tie. And this leads to a lack of high quality research, because it means different researchers are talking about different things. So I think that's an area that we can improve on as clinicians working in healthcare research. One fascinating group that published papers last year, they looked at cadaver studies. So they dissected out the tongues of babies and adults who had passed away. And when they dissected down the base of the tongue, they found that rather than just a string hanging out underneath the tongue, that it was actually a layer of fascia or connective tissue that spans the floor of the mouth. And inside in your mouth, the genioglossus is the big muscle in the tongue. And as the genioglossus muscle moves up and down, that fascia or the lingual frenulum moves with it. And so in the mouth, you have this balance between tongue stability, because you don't want the tongue flopping about, and tongue mobility. So you want the tongue to move adequately. Something that the authors in this study argued is that posterior tongue tie is completely an incorrect anatomical nomenclature. So in embryology, when the fetus is developing, the base of the tongue, or the posterior tongue, comes from a different origin in the mouth. So that they argued that the lingual frenulum or tongue tie, it only impacts the anterior and mid-tongue mobility. And when we watch babies feeding, that actually makes complete sense. So what's the incidence of tongue tie? So in the literature, there's rates of somewhere between 2 and 22 per 1,000 babies. So there's a wide variation of what's reported. One really large American study reported a rate of 14.7 per 1,000 babies. So just to put that into perspective, for a hospital like the Coombe or Holles Street or Rotunda, so a large maternity hospital, that would equate to about 120 babies a year with tongue tie. And I'm sure in our practice, we've all found that way more babies than that are diagnosed with tongue tie. And in fact, worldwide, and this has been replicated in Canada, Australia, USA, there's been an 800% increase in tongue tie. Reported in the literature is about half of babies with tongue tie will have some element of feeding difficulty. So why is it increased so much? Is it that it's generally increasing? Is it that more people are breastfeeding? Is it that there's an overdiagnosis of it? Because when we're diagnosing tongue tie, it's really important that we don't do a procedure on a baby that isn't going to benefit from it, and that doesn't have, so we don't want babies having unnecessary procedures either. So how do we assess a tongue tie? And this is where it gets a little bit confusing, because there's lots of different ways of assessing the tongue tie. The Carlos classification looks at physically where the attachment is on the tongue. Now, I think it's very difficult to measure 2 millimeters in a baby's mouth. So I find this is clinically quite a difficult tool to employ. Alison Hasselbacher's tool, the Hatlif tool, combines structure and function of the tongue, and you get a scoring system from that. That is quite time consuming, in that a full feeding assessment needs to be performed in order to get a grade or a mark on that. So this prompted people to develop the Bristol tongue tie assessment tool, or the BTAT tool. Admittedly, a lot of Alison Hasselbacher's work was borrowed, shall we say, for development of this tool. It's quite simple, and the Tabby tongue tie assessment tool kind of goes with it. So the Tabby tongue tie assessment tool is a pictorial representation of the BTAT. It's quite nice because when you're sitting with a baby, you can just circle the appropriate box and add it up. Many authors reported that if there's a BTAT score of 5 or less, that it's reasonable to perform a frenotomy. One Australian study, actually, when they looked at it, they brought that number down to 4. But most practitioners would tend to use a score of about 4, less than about 4 to 5 to perform a frenotomy. So when you're assessing a baby, and you don't need to be an IBCLC to do this. You can be a nurse or a midwife on the ward. You can be a peer supporter. You can be looking at the baby, examine the baby. So in my practice, I'll do a full clinical exam for the baby when we're assessing their feeding, because obviously there can be neurological things going on. There can be other things going on for the baby. Watching the baby feed. So how does the latch look? How are the mum's skills? Does she need some assistance with the latching? How does the latch feel for her? How are the nipples? So is there any signs of nipple trauma? When the baby's latched, is the baby actively sucking? How does that look? Is the baby's whole mouth moving when they're sucking? Or are they sucking in their cheeks and doing little nibbling that's telling you they're not taking an adequate feed? Is there audible swallowing? Are there any sounds? So is baby clicking? Can you hear that there's a loss of suction there, or is baby slipping off the latch? Is there any visible milk? So is there milk pouring out of baby's mouth and baby isn't able to adequately manage the milk flow? Do different feeding positions help? So sometimes just a tweak in feeding position will make a big difference for that dyad. So again, put simply, look and listen. Everything you need to know is there in front of you. You don't need to be a specialist. You know this information, you can support this family. So what's the evidence for frenotomy? So Joyce O'Shea, who's currently a neonatal consultant in Scotland, but was a trainee with me here in Ireland, published the most recent Cochrane review on this. And they admitted that the evidence for frenotomy is poor. So there aren't good randomized controlled trials out there to inform a meta-analysis. They found that release does not consistently improve feeding, but is likely to improve maternal nipple pain. One of the issues, and I'm sure you all find this in your practice, that many of the symptoms attributed to tongue tie, nipple pain, poor latch, poor feeding, unsettled infant, are common, and is particularly when babies are starting to breastfeed and mums are starting to breastfeed. So we don't want symptoms that can be helped or fixed to be attributed to tongue tie unnecessarily. And again, I've said it before, the most important treatment of tongue tie is lactation support. Evidence to suggest speech delay, poor dentition, sleep apnea, migraines are purely observational. There's nothing to suggest that performing a frenotomy in a small baby has any influence on these things long term. Many professional organisations and groups say that they're not connected. So when we're performing a frenotomy, we need to be really realistic about what we can hope to achieve and what we can hope to improve by doing the procedure.
And sorry, Denise, just to let you know, you're 14 minutes in.
Thank you. So for the frenotomy, when most people will use a scissors technique, some people will use a laser, and they feel that there's less bleeding and trauma associated with that. However, other practitioners feel that this causes more local trauma. There are complications of treatment, and that's not to be underestimated. Little babies can't tell us what's going on for them. So it is important that when we do a procedure that we weigh up the benefits and the potential risks for the procedure as well. Post-frenotomy, so ongoing lactation support. There's no evidence for wound stretching exercises. There's never been a trial that has compared doing wound stretching exercises and not. There's also no evidence for performing oral exercises afterwards. That doesn't mean to say that they're not helpful. It means to say that there isn't a trial that demonstrates doing them compared to not. Certainly if babies have a plagiocephaly or torticollis, that physiotherapy is essential in order babies' head movement to return to normal. And if we notice that, we'll refer babies to physiotherapy as well. So I'm running out of time, but just to talk, and I'm sure lots of people over the day will discuss about how to support breastfeeding. All the normal rules apply, protecting the milk supply, making sure baby is fed obviously, and trying to fix the problem. And post-frenotomy, this is really important as well. So to summarize, I told you it'd be nice and simple. So it's not necessarily how the tongue looks, it's how it works. It's how the mum and baby fit together. Simple tweaks can make a difference. Listening to what's going on, listening to the parents and the baby, finding out is there something else going on. And it's all coming back to no woman ever said she had too much breastfeeding support. So it's support either from peer groups, from their friends and family, and from midwives, nurses and lactation consultants. And I'm really happy to take questions. This is my one of my breastfed children who's now going to be 20. I just like this because she's so deliciously fat in the picture. So I'm really happy to talk and take questions, and I'd love to hear from you.
Thanks very much, Anne. That was really, really fascinating and really informative. So there's one question that's come in actually. What about the Martinelli protocol?
I'm sorry, I have to admit I'm unfamiliar with the Martinelli protocol. So again, every day is a school day and I'm going to go and read more. So thank you for that. I'll fully admit I have more to learn. So yes, I will read up, and I'm sorry, I don't know if anyone else can help answer that.
I can't help you. I don't know it either.
And thank you for the question, because I'll go away and learn more now. Thank you.
Okay, there's another question if anyone has the answer for that. But a question here, is it worth trying to harvest colostrum prior to giving birth?
Absolutely, and it's a little bit off the topic of tongue tie, but certainly it's been shown, and Denise will know more about this as well. It's certainly been shown in women who are diabetic during their pregnancy that there's benefits of harvesting colostrum, and no side effects, I guess, because that was always the worry. So it's definitely of benefit, and I think the kind of women, the type of women that are encouraged to express will widen. So yes.
Okay. Well, the great thing is somebody's actually come back about the Martinelli protocol to say that
great.
it's come from South America. Now that's all I can tell you. It's come in the chat. Okay. For the moment.
Oh, it's probably the Brazilian work. So yes, I'll read up more about that. Thank you.
Denise, do you want to move on? Or do
yes, thank you very much. I realise now that Lord Mayor Hazel Chu is with us, and she might be with us for the next half an hour or so, but I would like to introduce her at this stage. So I'd like to hand over now to Professor Gerard Feely, who will introduce the Lord Mayor of Dublin, Miss Hazel Chu. Thank you, Gerard.
Thank you, Denise. Lord Mayor of Dublin, Hazel Chu, thank you very much for joining us this morning, and we're honoured to have you address our breastfeeding webinar. Thank you, Lord Mayor.
Thank you, Jared. Hi, folks. I'm sorry I was late to this as well. So, but I was really glad I got to listen to Anne's presentation, because it brought back a lot of memories, I have to say, to when Alex was little. I was trying to find a photo there, actually. It was of when Alex was born. So Alex is now 2 years and going on 10 months, and I'm still breastfeeding. So at the beginning was more than a bit difficult, and I was trying to find that photo, but I couldn't. It was basically her as a baby pulling away with this face on, and it was that kind of repulsion and aversion that in the early months that kind of made me think, oh my God, what am I doing wrong? And am I going to continue this? So I would have been coming from a family that never breastfed. My mum didn't breastfeed us, and I think and none of her friends did as well. So I seem to hold on to this line these days that you can't be what you can't see. So if you can't see people around you breastfeeding, and you don't grow up with people breastfeeding, you automatically think, well, you shouldn't be, or you don't, it's not something that you like to do or try. So for me, when I first gave birth, I had thought, well, I'll try it, and if it doesn't work, that's fine. And I kind of held on to that mantra, but being super stubborn, even when it didn't work, I continued. And there was the tongue tie, there was the a rat of letdown, there was the issues with latching, there was a whole variety of things that made me really want to give up within the first couple of weeks. And I guess the other thing that also, as a new mother at the time, I found really hard was that there was no consistent advice and there was no consistent policy on things, which is why conferences like these and talks like these are so important, because you have experts that are tying in with each other to talk about what should be common policy and talk openly about what are the approaches, and actually have discussions about what are tried and tested in different areas. And it means that it's not that one approach is wrong or another, but it means that it's shared information. And what I found over the last 3 years was that there was, at the beginning of my journey, there was a distinct lack of shared information. But as we went on, especially, I have to say, I'm looking at some of the names here, and like Sue, like Anne, Denise, and I actually, since the start of my breastfeeding journey, I actually seen these names before, and they are names that always produce consistent information, which is really important, I think, in the times that we live in, because one of the things I've noticed with pandemic is that when there is no support that you can go to a breastfeeding group or meet people, that anything you can find online or share, such as platforms like these and talks like these at the moment, is essential to any mother or family. So, and I say family because I always find that my experience definitely was not just for myself or on my own. It actually seemed to have filtered through my whole family, insofar my mum, who was not a breastfeeder and kind of gave me one of those looks of whenever as Alex grew older, that she give me those looks of, should you still be feeding her? But then now it's a case of, oh yeah, okay, it's the most normal and natural thing ever. And it's the same with my brother and sister-in-law. Whenever they see me now feeding, it's fine. Whereas initially it was like, and it wasn't a look of judgment, but it was that look of, well, we don't see this often enough. And I guess that brings me back to why I find that in my role as Lord Mayor, if there is anything that I can support the panelists or any of the viewers and listeners here, please let me know, especially in regards to breastfeeding. Please let me know, because for me it was really important in the last 3 years to be able to shine a light on the fact that there is a certain kind of stigma still around breastfeeding. There's still judgment around it when it really shouldn't be, because it is the most natural thing ever. Whether you choose to breastfeed or bottle, that is entirely your own choice. However, if we can provide as much support and openness and being able to talk about things openly, I think that moves a long way. I had a really good call with Laura McHugh here, one of your panelists, who opened my eyes up to the statistics of breastfeeding in Dublin, and the sharp contrasts in areas that, I guess, in terms of geography, but in terms of support. And I think this is one of the things my office, I would definitely be looking to try to rectify. So I will be, I've already have a list of names and letters of people I need to write to in terms of wanting to make sure that we have lactation consultant public that's in Dublin North as well as Dublin West, because we have 3 in Dublin South. How do we improve things in terms of remote support for mothers and families? Because I know the hospitals do some of it, but I'm meeting the masters next Tuesday, so it'll be something I'll be bringing up in terms of how do they increase the remote support? How did they increase virtual, if virtual support is there in the platform, how do you make it engaging? How do you make sure that the mothers know about it? In terms of traveller discrimination, that was something that the first thing I asked Laura about, is because it's the first thing that I was interested in trying to make sure that people who are discriminated against don't face that extra added discrimination when it comes to breastfeeding. And there's a piece of work there I'm hoping to get started on, and then ultimately making Dublin a breastfeeding friendly capital, which I will have the support of council and the council officials on, because I think that's just a very simple step even. And I know Denise had brought that to my attention, how Limerick was already a breastfeeding capital, friendly capital. Why not Dublin? Why not every other city and town and village in Ireland? I know Tala, Laura was telling me, did very good work in this. And this is the thing, as our suburban villages and rural villages grow, because there is a lot of more drawn towards the village aspect now because of COVID, because of how communities work. This is the time where we should be also promoting the importance of community buy-in when it comes to breastfeeding, because there is definitely a lack of, I guess, publicly funded support in this space, and we need to improve on that. But there is opportunity there to push for that, but also push for the buy-in of the community in general. So I guess my job is to, on a Dublin base, to make sure that we are a breastfeeding friendly capital, and that people see that and people support that, and try to make sure we bring everyone along in that. And then lastly, I guess one of the things I really wanted to do in the house, but we can't at the moment, and hopefully one day we will, is to have breastfeeding groups in this house, because I know that there's so many voluntary groups. I always pronounce them wrong. So Kuju, damn it, I can't get their name right. So even after 3 years, that would have done immense amount of work. And I would have made friends with a good few of the people there. That's a voluntary based group that shows how we can support each other. So it would be amazing to bring them in and other groups in when the time comes, if the time comes. If it doesn't, then I'm hoping to try to set that up in a different way, that we do thank our voluntary groups, but also see how we can support each other in it. So like my thing is very simple for my term: promote, well, apart from the other pillars of homelessness and sustainability and anti-discrimination, is promote breastfeeding as much as possible. I will tend to be talking about it left, right and center. But I also am very conscious that others have been doing it so much longer and done so much more work. So if anyone here would like to tie into my office, if there's anything I can do, please let me know, and I will be happy to support and advocate in any way, shape or form. I did want to show you a picture of Alex, but I can't because I can't find the picture, but she is pretty adorable, I have to say, and she is pretty attached to boobs, as we call it here. So and I have to like there are a lot of people here's names that I have to thank for that, because I think it's been quite a journey. And for me, anyone who is going through that journey, especially in these difficult times, I would just say hang in there. And there are people, especially people among this forum, that you can definitely contact that can support you and try to get you further if you want to if you want to continue the journey. Thank you.
Thank you, Lord Mayor. What can I say? I'm delighted that you're the Lord Mayor of Dublin and putting breastfeeding on the map. And thank you also for mentioning the support groups, Cuidu, Lalette League and Friends of Breastfeeding. They are all so supportive and to breastfeeding mothers, and we love working with our support groups as well, support breastfeeding mothers. So thank you for taking the time to join us today as we celebrate National Breastfeeding Week at UCD.
A couple of questions came in relation to Anne's presentation. Anne, would you mind? Just with that present.
Yeah, I thought I was off the hook.
Sorry. So I see a question there. Hello, if an IBLC would like to learn how to release tongue tie, are there any courses they could attend?
So currently not in Ireland, and again, I know Denise has been looking into this as well. In the UK, midwives or qualified lactation consultants will perform frenotomies. I think compared to a lot of skills that our nursing and midwifery colleagues perform, that it's not that difficult. So I don't see why there can't be a pathway for developing this. It might be something that we need to push through and try. I know Denise probably has an interest in this as well, and a couple of my own colleagues, midwifery colleagues, are interested as well. So at the minute, there's no course or pathway that we can take in Ireland. There are people that go and train in the UK, but I imagine there would be certain documentation that would need to go through on Board Alternate just to kind of make that work. For me in my practice, my colleagues and I went and spent time with another practitioner and performed some under the watchful eye of one of those practitioners, and that's how we learned. Again, it's a skill that's learnable, same as all the skills that we complete in our jobs. So hopefully in the future, I hope that helps.
Yeah, no, that's a great answer. Thanks very much.
So while Gillian is getting the screen ready, I'll just be telling you all that we are very interested in breastfeeding research at UCD Midwifery. So currently we have 2 breastfeeding studies that are taking place. One is the Latch On study that I'm going to present today with my colleague, Dr. Marie Conway, and another study is in relation to diabetes and breastfeeding. So today we're going to share with you the Latch On study. So the Latch On study is a large, multi-centre, randomised control trial of perinatal support to improve breastfeeding outcomes in women with a raised BMI. And today I will be presenting the Latch On study with my colleague, Dr. Marie Conway, who is a postdoctoral researcher at the UCD Perinatal Research Centre. So this is a large study. The principal investigator is Professor Fionnuala McAuliffe. We also have some researchers from the UCD Perinatal Research Centre, Charlene O'Reilly and Eileen O'Brien. And we have a number of midwives and lactation consultants also on the team. We have some UCD midwifery lecturers, Denise O'Brien and Dr. Barbara Coughlin. So this is quite a large study between UCD Perinatal Research Centre and the UCD School of Nursing, Midwifery and Health Systems. The 4 hospitals involved in the study are the National Maternity Hospital in Dublin, the Regional Hospital Mullingar, St Luke's General Hospital Kilkenny and Wexford General Hospital. Why is Latch On an important study for primiparous women? Latch On is important because breastfeeding matters. Breastfeeding rates in Ireland are low in comparison to our international colleagues, but they are increasing. At hospital discharge, in 2019, 63.7% of women were breastfeeding, and that's exclusive and non-exclusive breastfeeding. At the first public health nurse visit, 57.9% of women were breastfeeding. At 3 months, 41.2%. We know that women with a raised body mass index are at increased risk of poorer breastfeeding practices. In Ireland, 50% of women have a raised BMI, that is greater than 25, at their first antenatal appointment. So what factors influence breastfeeding initiation and duration? When we were developing our study, we looked at these important factors. Socioeconomic status is important. We know that women who have a 3rd level education are more inclined to breastfeed. We know that father support is important, partner support, early skin-to-skin contact, mother and baby together, and maternal education, all aligning with step 3 and 4 of the Baby Friendly Initiative. We know that ongoing support from peers and health professionals is very important, aligning with step 10 of the Baby Friendly Initiative, and also the importance of assistance from an IBCLC, particularly where there are challenges to breastfeeding. So we have included these factors in our breastfeeding study.
So I'm just going to talk a little bit about breastfeeding and raised BMI. So rates of overweight and obesity are increasing globally, and this trend is also evident in pregnant women. So body mass index, or BMI, is used as an indicator of overweight and obesity. And here in the table, we can see that a BMI of 18.5 to 24.9 is defined as a normal BMI. A BMI of 25 to 29.9 is classified as overweight, and a BMI of over 30 kilograms per meter squared is defined as obese. Maternal obesity rates have increased from 16 to 18% from 2011 to 2017. So it is known that women with a raised BMI are at an increased risk of poor breastfeeding practices and low breastfeeding success. Overweight and obesity are approximately a 13% reduction in breastfeeding initiation, with an associated steep drop-off after breastfeeding is started. Previous research indicates that women with overweight or obesity are 76 and 83% less likely to breastfeed at 6 weeks and 6 months respectively, compared to women with a healthy BMI. So what are the reasons for women with raised BMIs having lower breastfeeding rates? Well, this could be down to physiological or anatomical reasons, psychosocial reasons, and also cultural reasons. So firstly, physiological reasons could be due to androgens. So androgens are known to inhibit lactation, and free androgens increase with increasing BMI. And mid-pregnancy, androgen levels have been negatively correlated with breastfeeding duration at both 3 and 6 months. Subclinical hypothyroidism may be the cause of overweight or obesity in some women, and thyroid hormones are needed for the initiation and maintenance of breastfeeding. Other reasons could include delayed lactogenesis, as well as which make the traditional breastfeeding positions more difficult in overweight or obese women. Psychosocial reasons then include things like confidence to reach breastfeeding goals, feeding practices of friends and family, maternal self-efficacy and body image, socioeconomic status, with women who are overweight or obese usually being from lower socioeconomic backgrounds. Women who are obese also have greater body dissatisfaction and lower self-esteem than women with a BMI in the normal range, both of which could impact on breastfeeding intentions. And lastly, cultural reasons may include women feeling uncomfortable breastfeeding in public, especially in Ireland, where it's quite a formula feeding culture here. So the lower initiation and duration of breastfeeding in women with a raised BMI highlights the need for additional support and encouragement for these women, both during pregnancy and postnatally. Successful breastfeeding support intervention elements include health professional-led counselling, non-health professional-led counselling, and peer support. Interventions that have been shown to improve longer-term breastfeeding outcomes, interventions that have been embedded into standard care, ongoing scheduled postpartum visits, tailored interventions to population needs, interventions delivered by health professional or peers or a mixture of both, and face-to-face support. So I'll now hand you back over to Denise, who will give some further details on the Latch On study.
Thank you, Marie. So the inclusion criteria: women aged 18 or older, women with a body mass index of 25 or higher, women during a first pregnancy, women with a single pregnancy. We like to recruit women between 26 and 34 weeks of pregnancy, because then we have time to implement the antenatal component, which is the education session to these women. We want women who are proficient in English, and also women who have a support partner who's willing to be on their breastfeeding journey with them. Our exclusion criteria: preterm delivery less than 37 weeks, and any condition requiring medication that is contraindicated to breastfeeding. So we have two study groups. We have the intervention group and a control group. The intervention group, this targets mothers and their support partner and spans the perinatal period, late pregnancy to 6 weeks following birth. Antenatally, women will attend a group antenatal breastfeeding session with their partner. Following birth and prior to discharge, women will receive a one-to-one lactation consultation in hospital. And following discharge, women will have support up to 6 weeks following birth. That will involve attending a weekly breastfeeding clinic, which may happen virtually or one-to-one. And also women will have a consultation each week with a lactation specialist as well. They can keep in touch by phone calls and text messages. Women in the control group receive standard breastfeeding support at each hospital. So what are the primary and secondary outcomes? We are interested in breastfeeding at 3 months postpartum. We're interested in breastfeeding initiation rates, mother's confidence with breastfeeding. We're also interested to know intention to breastfeed following the antenatal component, and also maternal and partner support and attitudes towards breastfeeding. So during COVID-19, how has recruitment been for our study? So we've had some challenges during COVID-19. Initially, at the National Maternity Hospital, recruitment was researcher-led. In the other hospitals, it was led by the midwife, the lactation specialist at each hospital. During COVID-19, we have called on our colleagues to assist us with recruiting. So midwives in the outpatient department, the diabetes clinic, community midwives are supporting us to recruit women and tell them about the Latch On study. We also have a lot of posters and leaflets in the outpatient department, semi-private clinic, fetal assessment unit, and many women are actually self-referring. They're reading the posters and leaflets and interested in taking part in our study. We're also using social media, Twitter, Instagram as well to advertise our research.
Denise, sorry to interrupt, 1 minute left.
Thank you.
So just a quick follow-up then from what Denise has said about the Latch On study. So our recruitment is still ongoing, so we're about halfway there with our recruitment numbers. So you can see we have 117 with our aim of 220. So I suppose Next slide, please. This is just the last slide to just, I suppose, summarise that the recruitment is ongoing. So please, anyone knows of anyone who might be interested in taking part, do feel free to pass on details of the study, and they can get in touch with us at the Latch On email address, which is on the screen now, so latchon@ucd.ie. So thank you very much for listening and for joining today's webinar.
Thanks very much. Just questions. There's no specific questions in yet. Just what is the document being referenced for breastfeeding statistics 2019 in the presentation?
So we have our rates for breastfeeding for 2019, and the breastfeeding rates are at hospital discharge 63.7. Now that is a national rate, Denise, and that would vary depending on each hospital. So some hospitals would have higher breastfeeding rates than other hospitals.
Sorry to cut across, Denise. The question is, what's the source? What's the
source?
document?
Oh yes, the HSC document, the HSC 2019.
So the actual.
Thank you. Thank you, Denise.
And then one other question, sorry, it's tongue tie. A public health nurse working is asking about lip tie. If anyone could answer that, if there's information available.
Yeah, and certainly it's something we've been hearing more about recently. There's a little bit of work our colleagues in Australia have done performing ultrasounds while a baby is latched on to feed. So you can imagine how tough breastfeeding is while someone is ultrasounding your baby at the same time. But looking at the extent to which the lip needs to phalange back or fold back while they're feeding, and really a neutral position does the trick. So while practitioners are releasing or performing frenotomies on lip ties at the minute, there hasn't been evidence to say that this is necessary yet. Again, I'll always keep an open mind on things, but certainly there's no evidence to say that anything needs to happen with a lip tie. Some dentists, when you get older for cosmesis, will perform that procedure. There's no real evidence to say that it impairs your dentition or anything like that. So really, once the lip can maintain at least a neutral position, it doesn't need to literally fold back on itself to feed. So I don't know if anyone else has an opinion on that.
Thank you, Anne. I agree with Anne. We don't have sufficient research on lip tie at the moment, but tongue tie is such an interesting area, and it's good to see that there is more of an interest in tongue tie, more research taking place, and I'm delighted to see that Anne has her own clinic at the Coombe Women and Infants University Hospital. So well done to you, Anne, on setting up that clinic at the hospital. Have you had inquiries from other hospitals, Anne, in relation to setting up a similar clinic?
Yes, unfortunately, COVID has ruined 2020 for many reasons, but certainly other hospitals were keen in setting up a service, and other consultants have contacted me about this. I feel very strongly that cost shouldn't be a barrier to accessing service in Ireland, so that obviously private providers are available, but that isn't suitable for everybody. So that was part of why we set up the clinic in the Coombe, that we didn't want cost to be a barrier to accessing services or support. And you can hear more about that on Monday afternoon if anyone is interested.
Denise, there's a question for you for the presentation. For yourself and Maria, if you could answer it. Is the 67% who are breastfeeding at hospital discharge inclusive of those women who are leaving hospital solely expressing? So
that answer I cannot answer at this moment, but I will speak to Laura McHugh, the National Breastfeeding Coordinator, and we will have that answer by the end of the webinar today. So thank you for asking that question. It's a good question. I think we're now ready to move on to our next. Actually, Laura, do you want to answer that question? at the moment?
I can, yeah. So the discharge figures from hospital, the any breastfeeding figure you quoted there, that includes exclusive breastfeeding and babies who were topped up during their hospital stay and or are combined feeding leaving hospital. So it's the any breastfeeding rate going home. So it includes exclusive breastfeeding and supplementation.
Thank you, Laura, for that. Okay, I believe we're now ready to move on to our next presenter, who is Regina Kincaid. Regina is a midwife, lactation consultant, and a breastfeeding mother of 4. And I had the pleasure of working with Regina when I worked as a clinical midwife specialist in lactation at the National Maternity Hospital. And Regina is an excellent pioneer of breastfeeding and very supportive of breastfeeding mothers. And we look forward to hearing Regina's presentation, which is top tips to support breastfeeding mothers.
Thank you, Denise, for the introduction, and thank you very much for having me here today. I'm just trying to share my screen. Can you all see my slides?
Not just yet, Regina. It's on the way. Yes, there we are.
Okay.
Thank you, Regina.
Okay. So as Denise mentioned, I'm a midwife and a lactation consultant, and I have been breastfeeding for 7 years in total so far. I'm currently still breastfeeding my 2.5-year-old toddler. So the top tips to support breastfeeding mothers for this presentation today, I have taken from my personal and professional experience. I've looked at the 10 steps to successful breastfeeding. But first and foremost, I really wanted to hear from breastfeeding mothers firsthand how they would like to be supported with breastfeeding in hospital, the early days postpartum and beyond. So what I did is I put up a post on the Extended Breastfeeding Ireland Facebook group. I'm a member of this group myself. They are a breastfeeding support group for women who live or have lived in Ireland. And to date, they have about 20,000 members. And I have to admit that their response was very overwhelming. I received 203 comments. I won't have the time to go through each and every comment today. But if you do have access to the group yourself, I really encourage you to read through the comments. They're very insightful and informative with regards to the breastfeeding care received. And the group welcomes healthcare professionals with an interest in breastfeeding. So what some of the mothers of the group expressed the importance of an attendance at antenatal breastfeeding preparation classes, be that virtually or face-to-face. And in those classes, they would like to be given a realistic view of breastfeeding. While we all know that breastfeeding is natural, it often doesn't come naturally to many moms and babies. It is like a skill that moms and babies learn together in the early days postpartum. And they would like to know that sometimes it can be hard initially. Also, they want to receive education in breastfeeding challenges, so not just information on attachment and positioning, but also some of the common challenges that they might encounter on the way. They would also like to receive information on especially what is normal newborn behavior, especially also when it comes to sleeping patterns, and that is quite common for newborn babies to wake frequently, not just in the early days, but throughout the whole of the first year of baby's life. And they really appreciate leaflets on contact details for postnatal services and the community support available. Whilst often the antenatal pathway, and I can speak from my own experience going through antenatal care here in Ireland, is often very straightforward. Sometimes it's a little bit harder to navigate through the postnatal follow-up. And I know that at the moment it's particularly difficult, but support groups like the Friends of Breastfeeding, the Latch On and McHugh, they all offer virtual support as well. Then it's also important for mothers to not just attend a class, but be regularly informed about breastfeeding during their antenatal checks, be that by the midwife or when they go and see their GP. And that's including second and third time mums. Especially for them, they mentioned that they would like to be asked about their previous breastfeeding experience and not have the assumption made that just because they breastfed before, they'll be grand this time around as well. And then to include a breast check in the antenatal care can also help to identify issues or potential issues for postpartum and put a care plan in place. For example, for inverted nipples, we all know that inverted nipples, it doesn't mean that if you have inverted nipples that you won't be able to breastfeed, but sometimes we can put a support pathway for those women in place, and they can have an idea of maybe the challenges that they might encounter initially. Then another one of the essential tools, apart from the obvious of positioning and attachment, is to teach mothers how to hand express, and as they can manage a lot of breastfeeding challenges through hand expressing from early on, be it if they're separated from their baby or baby is sleepy. Also, if in the case where they're not able to access a pump. One of the randomized trials comparing hand expressing with breast pumping for mothers of term babies whose newborns feed poorly has found that hand expressing in the early days postpartum period appears to improve eventual breastfeeding rates at 2 months after birth compared with breast pumping alone, and further research is needed to confirm this. It also helps mothers to familiarize themselves with their lactating breast, as it takes sometimes a little while to get used to your breast making milk, and so abnormalities can be identified early, such as blocked ducts. Another piece of research by the anthropologist Van Nesterijk found that the popularity of breast pumps may lead professionals to overlook the technique of hand expressing, and that is maybe also attributed to the active marketing of breast pumps. But I'm sure a lot of us do that already, but it'd be great to have teaching and assessing the ability of mothers to hand express in our routine postpartum checks, on the admission to the postnatal ward, on discharge, and at the first home visit. And there are a lot of very educational videos available. One of the popular ones is the one from Dr. Jane Morton at Stanford University. The HSE My Child has a step-by-step guide for hand expressing, and the Best Beginnings charity in the UK have a very educational video on hand expressing of colostrum and mature milk as well. So they separate that because hand expressing of colostrum, with colostrum being quite oily, and it takes a little bit, it's a bit slower to collect the drops, and then for the mature milk when you get the sprays of milk. Similarly to teaching hand expressing is the teaching of breast compressions. Did you know that the second most common reason why mothers give up breastfeeding in the first 2 months postpartum is the worry of low milk supply? And the purpose of breast compressions is to continue the flow of milk to the baby when the baby is only suckling without drinking. Breast compressions can actually simulate a milk ejection reflex and also stimulate a milk ejection reflex. And this is a quote by Dr. Jack Newman from the International Breastfeeding Center, who was describing breast compressions as a technique, but I'm sure women have used this technique for centuries without it being given a name. But on his website, there are very useful videos for mothers and healthcare professionals alike to learn about breast compressions.
Regina, sorry to interrupt you, 1 minute, okay, left.
Thank you. Then also, if we teach mothers different breastfeeding positions, they can find out what works best for them, because not every mother and baby pair finds the cradle hold as the most useful position for them. Some babies are very small, and some mums have large breasts, so they might find the rugby hold more beneficial, and the side lying position can be very useful for mothers to rest as well. And one of the things that came up from some of the mothers of the Extended Breastfeeding Ireland group is that they have found that, or they have reported that bed sharing was an important contributor to their successful breastfeeding journey. Professor Helen Ball from the Durham University has found that bed sharing promotes breastfeeding initiation, duration, and exclusivity. And in their same research, they've also found that on any given night in England, 22% of babies will bed share with their parents, whether that is intended or unintended. And that's quite a large number. But we also know that bed sharing or sharing a sleep space with your baby is associated with a risk of cot death. So the official advice is not to bed share, as this can lead to overheating or suffocation. But I think to find practical solutions to this complex issue it goes beyond the scope of today's presentation, and it warrants further multidisciplinary discussion and review of the research and evidence. We should always focus on finding breastfeeding solutions to a breastfeeding problem and not look at formula as the first alternative. There are other alternatives of supplementation, and also of the methods of supplementation, i.e. that breast milk can be given by a cup or supplemental nursing system.
Regina, can I stop you there for questions? Sure. Would that be okay?
Sure.
Okay,
yeah.
Thanks. There's a few coming in. I'm sorry now to interrupt at the end. So, establishing and protecting mum's milk supply while issues with latching are worked through is so important to establishing successful breastfeeding. Therefore, what supports are there for families to access hospital-grade pumps for expressing? That's the first question. If you were in the
hospital-grade pumps once they're discharged from hospital?
Yes.
So that would be usually a rental scheme. I know the Medicare company, they are linked with pharmacies and across the country, and usually you can order that online, arrange it online, and sometimes pick up from the designated pharmacy. And it costs about €100, as I believe, to €120 per month. And additionally, you need the double pump kit usually. So that's that's the way it works at the moment.
Okay,
great. They have to privately pay for it.
Okay, we've time for one more question then. Can we do more to offer financial support for renting pumps in those vital early days weeks? So it relates to question. Your answer.
Exactly, yeah. I mean, in an ideal world, and especially also for moms whose babies are in the NICU, I know if babies are in the NICU, they get a little bit of a discount. Also, there is tax relief, I believe, through the, I think it's the, when you reclaim your taxes through revenue, you can, if you have a document by your GP or by your pediatrician, you can claim tax relief on a medical pump as well.
Thank you very much, Regina.
Well, this is just my last slide up now, so I'll continue with just the last slide. Finally, we should always be mindful of the words that we're using when we're, and the language when we're talking to families and breastfeeding mothers. We should have meaningful conversations with them, as we like to empower them. And instead of saying sentences like "that baby is starving," that many might have heard, we should keep it positive. And even if we know as professionals that the baby is hungry and needs feeding, you could say something like, "Your baby is showing hunger cues. Would you like me to assess your latch and perhaps help you with hand expressing?" And even if formula is necessary, medically indicated, because baby is not gaining weight, and I've learned this from Denise, is something we could put it in a way that we say you're giving your baby all the nutrients and the goodness, the omega-3 and the antibodies through your breast milk, but your baby requires a little bit of extra calories. And the way we say things has a huge impact, and ultimately we like to sometimes just saying things like a pat on the back and you're doing amazing goes a long way for many moms. And just the final slide here is the references that support today's presentation.
Thank you very much, Regina. That was a very interesting presentation, and I really agree with you that language matters. How we communicate with mothers is so important. It's a very sensitive time for mothers as they're establishing breastfeeding, and it's really important that we are careful how we broach the subject of supporting mothers on their breastfeeding journey. So thank you and well done on that presentation. And at this stage, I'm ready to hand you over now to my colleague, Dr. Gillian Paul, who's a lecturer and professor in the School of Nursing, Midwifery and Health Systems. Thank you, Gillian, for co-hosting now.
Thanks, Denise. And thank you, Regina. That was a really fabulous presentation, really practical tips. So next up, we're delighted to welcome Sue Jameson, the President of the Association of Lactation Consultants in Ireland. Since studying developmental psychology in Trinity College Dublin, Sue has worked in the field of education and parenthood and breastfeeding education support for over 30 years. She works as an IBCLC in private practice. She first certified in 1989 and recently recertified after 30 years of practice. In addition, she is a senior breastfeeding tutor with McHugh, and many of you will know Sue over the years has been a great advocate for breastfeeding. The title of Sue's presentation today is Breastfeeding and Avoiding Formula Supplementation. Okay, Sue.
Thank you very much, Gillian. Well, I am absolutely delighted to be here this morning, but I'm really sorry that we're not in the nurses' sitting room in the National Maternity Hospital with the scones and the coffee and the chat. So we missed that a lot. And thanks to Denise and the team in UCD for the invitation to speak this morning. Today's title is Breastfeeding and Avoiding Formula Supplementation. And when I first thought of it, I thought, ooh, that could be a great exam question. Just stick the word discuss at the end of that and you're off. So that was what first struck me. When I was thinking around the topic, I'm sorry, I'm not going to show you any more slides today. I'm just going to talk to you. My thoughts were, are we going to talk about supplementation in the first week of life, or are we going to talk about supplementation in general? But obviously, since it has a profound impact on breastfeeding outcomes, I'm going to stick with the first week. There's been many studies over the past couple of decades linking early supplementation to shortened duration of breastfeeding. There's people like Piero et al. In the Journal of Breastfeeding Medicine 2016, and the most current one that I was looking at is a paper called In Hospital Formula Feeding and Breastfeeding Duration by McCoy and Heggie, and it's from the American Association, or the American Academy of Pediatrics. It was published in March of this year in Pediatrics, the journal, and their paper is entitled Strategies to Reduce In-Hospital Formula Feeding, and including prenatal education, peer counselling, hospital staff and physician education, and increased skin-to-skin contact. So those are all the things that we already know about. They've been mentioned on many other occasions. So why does the need for supplementation arise? Well, there are many reasons, and some are infant-related and some are parent-related. In this talk, I'm going to mention variously mother, parent, birth parent, birthing people, because I wanted to be as inclusive to all people who we might meet in the birth arena. So many of the things that come up are infant related, and things like hypoglycemia, jaundice, poor latch or no latch, various oral issues such as tongue tie, as I had mentioned, cleft lip and palate, are the baby who's very floppy, a hypotonic baby. It's just very hard to get those babies to the breast and feeding effectively. So for that reason, some extra food might be offered. And on the maternal side, we might have postpartum illness, or in some cases, somebody else has determined an apparent lack of colostrum. Somebody has squeezed that person's breast and said, oh, I don't think you're going to be able to do this. So sometimes it's iatrogenic. It's an induced situation where fear has been brought into the equation that wasn't there before. Sometimes there are no breast changes during pregnancy or thereafter. And when the onset of milk after 72 hours is slow, we would describe it as delayed lactogenesis 2. But getting a good latch right from the start is the key to switching on the system. So we want to sort of think around latch. What is it that makes a good latch? And I'll come back to that in a moment. And sometimes some support feeding might be needed to bridge the gap between the baby's birth and the mother establishing breastfeeding. I'm not going to say successful breastfeeding, because what we want is for parents to have an experience of breastfeeding that matches with their expectations. So some people have an expectation of being able to breastfeed for a couple of hours, a couple of days, a couple of weeks. So whatever that person's expectation of breastfeeding is where we're trying to go. So we're going on the journey with them, and it really is all about the language. Most of the speakers this morning have mentioned the importance of language, and it really is the key to unlocking better outcomes, is how we say what we want to say. So the first thing that we want to note is almost everyone can make some milk. There's rarely a time when somebody can't be helped to give whatever colostrum or milk that they can produce to the infant. So there's never a time whenever we would say, oh, don't bother. You're only making 2 mils. You're only making 5 mils. In theory, we should only ever be offering formula if there's a medical indication. This area is open to some debate as to what constitutes a medical indication. So I'm certainly not going to go there today, because that's a whole other day's work. But sometimes they may need to have some support feeding. So the emphasis should be on using all of the milk that they can provide first. I absolutely endorse Jane Morton's work here. I was at the International Lactation Consultant Conference in Atlanta last year, and Jane gave a wonderful presentation all around hand expressing and teaching people to be comfortable with handling their breasts. Getting the baby comfortably feeding is the first milestone. So it should never look right to the onlooker. We should never look and say, oh, that looks like a great latch. We should be saying to the parent, how does it feel? Does that feel comfortable? Can you feel some pulling sensations into the breast? How does it feel? So it's all about the feels, and everything to do with breastfeeding is all about the feels. However, in the hospital setting these days, it would be very rare to see mature milk, because most dyads are discharged before the onset of copious milk supply. And this is where your community-based support comes into its own. And we really, truly need lots more, because between the public health nurses and community-based IBCLCs in private practice, the 3 big voluntary groups, we're still not getting there. We're not meeting the needs of the people in the community. So therefore, supplementation from the early weeks and onwards is likely to continue without good one-to-one support. And how else can we avoid unnecessary supplementation with formula? The usual helpful practices such as prolonged skin-to-skin immediately after the birth, and we need to combine that with skilled, timely help and support. Anticipatory guidance is a key thing here, so we can cue the mother and her support team as to what to expect. And a really vital thing, and this came up from some of Regina's women and other people that she spoke to on Extended Breastfeeding Ireland, were simple things like make sure that the call bell is within reach. We've had stories back of people who would like to breastfeed, they couldn't reach the call bell, they were in a room on their own. So please make sure that the person has access to the support that is there for them, because if they can't shout for help when they need it, it's not much use to them. If they've had a C-section and their baby is in a cot at the end of their bed and they can't get to them, that's no help. So we need to be sure that everything is optimal for the mom to establish good milk production and comfortable breastfeeding. And actually what's very interesting is to have a look at the results of the National Maternity Experience Survey. And it's, as I say, it makes very interesting reading, because a high percentage of people said their hospital stay was good in terms of their care during the birth process and care immediately afterwards. And the lowest scoring pointer from all the hospitals across the board was in the area of support with feeding afterwards. So it is an area that we need to look at. We accept the WHO statement that express breast milk or bank donor human milk is the best choice for the baby who does need a little extra food. But in practice in Ireland, we wouldn't see this outside a NICU setting where there is donor milk available and where mothers and their partners work extremely hard to establish colostrum and milk for their preterm baby. So why is infant formula very prevalent in Ireland? Mainly because it's acceptable to most, and we actually have a very long, very strong history of not breastfeeding. So we're a net exporter of the product. We also permit extensive saturation advertising and influence on healthcare professionals in the form of sponsorships, bursaries, conferences, lunches, you name it. And we need to do more to uphold the WHO Code of Marketing, just for starters, to really push to remove the influence of the companies from the day-to-day business of healthcare provision. And it's definitely starting. We can see improvement all the way along. The INMO have removed advertising as best they can from publications. They're still allowing some specialist formula advertising. However, parents can't tell the difference. They're only allowed to advertise things from 6 months and onwards, but everybody thinks they're advertising infant formula. They're not. It's follow-on milk. It's the only thing that's prohibited, and hopefully follow-on milk will join that in the fullness of time.
Sorry to interrupt you, Sue. 1 minute.
Okay, I'll leg it. We also have a system where our staff are time poor. We don't have sufficient dedicated lactation posts. The WHO recommends 1 IBCLC per 1,000 live births, and we have a tiny fraction of those numbers. And again, just to quote the National Maternity Experience Survey of 2020, the lowest scoring question related to support and encouragement provided to women with feeding their babies while in hospital, and that was mirrored across all maternity care settings. When mothers and babies are struggling in hospital, infant formula seems like a quick fix. Often it can leave parents disillusioned and feeling inadequate, but often the back half of the message is missed. And that is, you can turn this around. With help and support, this is not forever. If we have to give your baby a little bit of extra food to get some energy, to get feeding, while we're seeing what's going on, then that's what we'll do. But it's not forever. It's a temporary and transient time. So time and patience with lots of skin to skin. Hands-off practice, please. Staff need to gently coach and instruct the parent, but don't do it for them. This takes time, and often it's the one thing that's not available. Hands-off practice empowers, hands-on rarely does. Encouragement, smiles, praise, positive affirmations can all help, because producing milk is a right-brained activity. Checking for milk can often switch off the very thing we're seeking to encourage. So repeatedly asking a mother, has she managed to express anything yet, will often have the opposite result. Celebrate every drop and don't use 50 ml containers. 1 and 2 ml syringes only, please. Jane Morton's other video reference that I would put in front of you is firstdroplets.com. So if Justin wouldn't mind sticking that up in the chat for me, it's firstdroplets.com, and that celebrates every drop of colostrum. The language is important. I'm not going to mention the Dame trial, although we do know that some parents were disillusioned by taking part because they didn't produce any colostrum, but that's another day. It's not for nothing that many lactation practitioners are referred to as boob whisperers. One was once told that she could charm milk out of a turnip. So in conclusion, can we aspire to a place where if infant formula is required, it should be given in the smallest amount necessary by a method that will not disrupt the potential for continued breastfeeding? I finish with something from the late and great Maya Angelou. People will forget what you said. They will forget what you did, but they will never, ever forget how you made them feel. So make them feel good. Make them feel positive about the journey that they're about to embark on as parents. It's all about the feels. Thank you.
Thanks so much, Sue. Just to say, Gillian, you're chairing. We have little time for questions. We're running late.
Yeah, why not?
Brilliant. Just to say, a lot of it is, agreement of what you've said. An awful lot of really positive feedback. But just to say, 2 questions then. I had a cesarean section with my first, and as a result, it took a week for my milk to come in. The first of my woes. I am now pregnant again and really want to succeed this time. What are your thoughts on pumping to increase supply when a baby is born, and supplementing with formula if milk is slow to come in post-cesarean section? I would like to just check on this.
Okay, that covers a whole variety of different bits and pieces. The main thing is don't panic, because second lactations are inevitably and invariably better than first, because you've laid down a whole heap more prolactin receptors, and even post C-section second time round the milk comes in a whole lot quicker. And particularly in the first case, if it was an emergency following a long labour, it can take a few days extra. Second time round, it's not something that I see that often. I see a normal incoming of milk with second time cesarean mamas, and if that person would like to make contact with me privately, I'm happy to talk to them.
Thanks very much. One last quick question then. What support advice is given to mothers who don't give up breastfeeding but their breast is leaking?
Sorry, just give me that again.
Sorry. What support advice is given to mothers who don't want to give up breastfeeding but their breast is leaking? Okay, so normally we would associate the leaking of milk with the early days, with the incoming of copious supply of milk, and often it is to do with 2 factors. One, it can be as simple as just muscle tone in the nipple, and sadly there is no Pilates class for nipples, so sometimes they leak, sometimes they don't, but they usually leak if the gaps between feeds are a bit longer, or if the mother experiences another baby. Any baby will switch on a letdown in a lactating person. So using a breast pad obviously is the first thing. A lot of people will use the old-fashioned good old technique of just folding your arms and putting a bit of firm pressure on the breasts. That will cause the areola to contract and slow down milk leaving the breast. And again, we'd want to look at the supply there. Has that mother produced an awful lot of milk, and can we do something maybe to tame that supply a little bit? Any of the volunteer groups are wizards on this, so contact any counsellor from any of the 3 community-based support groups or the local public health nurse, and they will get a trolley load of information that'll be able to help them with that. Thanks very much. I'm going to pass back on to Gillian.
Okay. Thank you, Denise, and thank you, Sue, for such a refreshing talk as ever, and you bring such enthusiasm and positivity to breastfeeding. It's fabulous. So our final speaker today, it's our pleasure to welcome Laura McHugh. Laura holds the position of National Breastfeeding Coordinator since 2018, with the responsibility for driving the implementation of key actions within the HSE's Breastfeeding in a Healthy Ireland Action Plan 2016 to 2021. The National Breastfeeding Implementation Group are focusing on the following priority areas: improved governance and structures to support breastfeeding, improved staffing and resources for breastfeeding support within maternity services and primary care, education and training for healthcare professionals, and collection and monitoring of breastfeeding indicators. So the title of Laura's presentation is Breastfeeding in Ireland Now. So I'll hand over to Laura.
Good morning, everyone. It is lovely to be here today. I want to see, can I share my screen? Gillian, you might need to help me. Maybe.
Okay, I'll try.
Okay, someone.
Okay, leave it with me and I'll...
No bother. Anyway, I'm the big bad HSE person on to sum up the end of the presentation, and thank you so much to Anne, Denise, Marie, Sue, Hazel, and Jerry so far. And it is, I suppose, and thanks to Denise and the colleagues in UCD for arranging this. This is one of 4 webinars that I'm aware of anyway, and it's a great opportunity in COVID times to try and, I suppose, share and kind of share people's experience and to hear what practices are going on, and just to get a bit of support for each other, I suppose. You know, everyone here is the same goal of supporting mothers to breastfeed for as long as they can, and to try and improve mothers' experience and improve breastfeeding rates in Ireland. So we, I suppose, in the National HC Implementation Group are really committed to promoting best practice in infant feeding, and to really, I suppose, try and change the culture that promoting feeding as the normal and the optimum feeding choice for mothers, and to support all mothers regards to infant feeding, to have information and support available free to them that are free from commercial influences. I suppose it's always refreshing to hear Sue you know, summarize some of the key challenges for all of us, I suppose, to try in supporting mothers. And yeah, some of the code of marketing ones particularly are quite challenging, and we've an awful lot to do. I suppose National Breastfeeding Week is a time, I suppose, to support and encourage and kind of congratulate all mothers and all staff in terms of their efforts in trying to support breastfeeding mothers. This year it's very different, obviously, with COVID, but also this week we've had a number of publications out this week where breastfeeding is being mentioned, and Sue talked about some of the results in the National Maternity Experience Survey there. Those other findings in the maternity survey, which I thought was quite interesting as well, and something for us to reflect on. Only like 35% of mothers are using breastfeeding support groups that are available, and in a time when we know, we need to, I suppose, trying to meet mothers where they're at that. So it's just interesting findings about trying to meet the needs of mothers where they're at, and we have community supports available. And obviously with COVID times, if the groups can't meet face to face, but our voluntary colleagues from the Latch League, McHugh, Friends of Breastfeeding, and our HSE public health nurses are trying to find other ways of meeting mothers' needs at the minute. I suppose encouragingly, it's good to hear from the Maternity Experience Survey also that most mothers are receiving skin-to-skin contact after birth, and we would like to see that be maintained, and obviously for more skin-to-skin contact for longer. Also, you might be aware the 1 to 4 guidelines from the Department of Health's nutrition guidelines were launched yesterday. They came out as well. So we had an opportunity to contribute to those guidelines and try to reaffirm that breast milk is an important part, and it counts towards the servings of milk with the dairy food pyramid. So we're very keen to promote that breastfeeding is it should be a normal, and should be kind of promoted as part of the milk intake of babies over 1 year. So those guidance and practices will be issued to all healthcare professionals, and that's the guidance for parents that will be sent out. So just a couple of slides. It won't take that long. I suppose we said, on the screen there, the National Breastfeeding Implementation Group we've a range of actions under these 5 areas. This is what the National Breastfeeding Implementation Plan are really trying to work towards. I'll just give an update on some of these areas. Move on to the next slide. So just about the rates of breastfeeding, we are currently able to track, I suppose, breastfeeding initiation rates in hospital, the first feed following birth, through to the 3 months developmental checkup. And there are 2 data collection systems in place, and the more recent data for hospitals is based on the Irish Maternity Indicator System data, where we are tracking exclusive breastfeeding from birth, which is a subtle difference from the MPRS data, which tracks breastfeeding at the time of discharge from hospital. So it may account for some of the variances in the rates there. Now, I know there's MPRS data later than that, so I have to update my slides available to this as well. So where we're at, we're going to see 63% of babies are initiating feeding immediately after birth, and the rates then at first PHN visit, slight drop off of 57.9%, which that includes any breastfeeding and formula feeding, and the exclusive feeding rate at the first PHN visit is 42.2%, and then that drops to 31.2% at the 3-month developmental checkup. So currently in Ireland, less than a third of babies are exclusively breastfed at 3 months. So that is quite sobering, statistic. So just a little bit about COVID-19 and breastfeeding and the implications on that this year. So look, you know, it's been an enormous challenging year for everybody, not least for the mothers and the families that have given birth this year. And the impact on feeding, I suppose we're beginning to understand that. We're beginning to understand that a little bit, and we are trying to support mothers as best we can virtually. And there's been an awful lot of work done by to various people in Ireland, our voluntary colleagues, the Latch League, McHugh, Friends of Breastfeeding, all immediately adapted and embraced virtual forums and are running online support groups regularly. And the organisations have told me that in August alone, there was 80 online breastfeeding support groups run by the Latch League, McHugh and Friends of Breastfeeding in August. I think they are to be congratulated and is a great testament to their commitment in terms of just adapting and utilising virtual means of supporting mothers. We've worked with ALCI over the summer and with Sue particularly to look at kind of trying to look at guidance for people around their own work and kind of what's safe to do so under the various I suppose tiers of support that people would provide. We've developed guidance for the voluntary breastfeeding group sector, which will be relevant to, I suppose, HSE workers as well, in around how voluntary or how breastfeeding groups can get up and running again under the guise of the public health guidance, and that will be challenging to say the least. And I think virtual forums will be realistic, in the meantime, and it's something that we need to, I suppose, understand what's working there, and seeing how we can kind of try and expand and kind of grow that virtual space more to meet the mothers' needs online. Fully understand virtual will never fully replace the need for connecting with mothers who are going through the similar thing in your area at the same time. The importance of local breastfeeding support group in terms of the social and the emotional support for mothers, as well as getting skilled breastfeeding support. It is very important, and we're trying our best, and we will see, I suppose, what the rates and what kind of the outcomes from that perspective look like. We are hearing feedback from various mothers, people who've first-time mothers, second-time mothers, third-time mothers, and all of their various experiences, positive and negatively towards COVID and their engagement with the services and what that's looked like. We have our own Ask the Expert service run by the HSE and My Child, and I suppose over the last 6 months we have seen a significant increase in the demand in that service, and that really correlated with the reduction in or the cancellation of the face-to-face groups, but also people looking for information online. But the types of questions people are looking for online has also changed, and I think that's directly related to the fact that people maybe are not meeting up as regularly and meeting other mothers, as much as they would, and they're looking on and they're looking to online, to actually get the information that they need.
Let's cut across you, Laura. Just let you know, 1 minute left.
Yeah. Okay. So just I suppose in terms of the big things that we're trying to, I suppose, improve on with the health service governance structures, maternity services, we are very much committed to improving and striving for improved infant feeding practices based on the infant feeding policy of 2019, the updated guidance from WHO. Pleased to say we had a national audit of the infant feeding practices maternity services, which will form the basis for implementation plan for revised baby-friendly standards. We are constantly, I suppose, striving for additional resources through the national estimates process in the HSE. We were sanctioned 3 new posts for 2020. Those posts haven't been filled yet. They're with HR in terms of just getting them into posts, and they were going into hospitals which did not have lactation support currently there. There's been additional, I suppose, post-retirement and vacant posts filled in 2024, 4 new posts in maternity services. And our public health nursing colleagues are continually, I suppose, trying to prioritise additional child health posts within the existing resources. So we are behind the scenes constantly advocating for additional support and investment in resources. Just move on to a couple of policies this year, which people will be very eagerly awaiting. The breastfeeding policy for our public health service employees. So us as HSC staff, we really want to be leaders and champion to support our own mums when they're coming back to work. COVID has significantly delayed the implementation of that policy. It should have been signed off last February. We are striving to sign that off and get that implemented this month. And our HSC marketing and breast milk substitute policy, which Sue alluded to in terms of the issues with regards that to protecting our staff and protecting our parents in the hospital, that will be signed off this year. And both of those we thought we'd have them over the line before now, but anyway, the year that's in it that has delayed things. And you can see there's a range of other infant feeding policies in terms of what the HSE have kind of updated in the last number of years. The campaigns piece, I suppose, in terms of the HSE has been one of the most significant, I suppose, pieces around trying to engage parents in terms of where they're at in the online space. The My Child website has seen, I suppose, additional traffic and engagement with parents, and it's, I suppose, our go-to website for all trusted child health information, right through from pregnancy to toddlerhood, and breastfeeding is part of that. There's 2 pregnancy books, our My Pregnancy book and the My Child books, that parents are given free in antenatal care and postnatal care by our public health nurses. And we have our 2 breastfeeding booklets, and our premature baby booklet will be updated later this year. There's some of our colleagues updating that with new content. Our Ask the Expert service, because I was constantly asking people to kind of let mothers know about the service, and we have seen a kind of a 57% increase in demand for that services this year. I hope you will hear some breastfeeding adverts on the radio this week and over the next month. We, I suppose, have a target additional campaign resources towards breastfeeding, particularly for this month. But we have a very strong presence on social media and through Instagram, Facebook, and Twitter. And we are seeing, I suppose, positive results in terms of hits on our pages and viewed content and all of that stuff. I don't fully understand, but we work closely with our communications colleagues around that. So they're just some of our pictures of kind of the breastfeeding booklet and the My Pregnancy and the 0 to 2 years content book that it is available. I won't go through this, but basically our Ask the Expert service, we evaluated it 2 years ago, and it's a very highly valued service by mothers, and we know the various types of questions that mothers ask us about, and pleased to say that the limited impact that an online service can have in terms of supporting mothers on their breastfeeding journey. We're pleased that the mothers find the responses that are given by our lactation consultants very comprehensive, empathetic, and really worthwhile in terms of helping their continued breastfeeding journey. Yeah, and that's kind of that's it really. So I suppose everyone has their own experiences around breastfeeding. My breastfeeding experience is 10.5 years old, and delighted to say that obviously we are heavily guided, and I am striving to make sure breastfeeding is talked about in terms of the up-to-date, most empirical evidence that's available, and our National Breastfeeding Implementation Group will take all of the advice and all of the recommendations in international policies. But I suppose, we're all human, and we all have our own experiences, cultural experiences and personal experiences to bring to them. So I am very pleased to be a breastfeeding mammy of 3 boys, and my oldest little boy there is 10. So yeah, he's my personal input into all of this. So thanks everyone. Delighted to answer any HSE questions you might have.
Okay, thanks very much, Laura. There's a lot of, we've time for 2 questions, have we, Gillian?
Yes, yeah.
Brilliant.
We may
okay. First of all, just to say a lot of comments about the HSE breastfeeding policy, and I think you've answered that, Laura, when it was coming out. People were asking about it.
Yeah.
Okay, and then in terms of questions, we were tight on time, and I really apologise. We want to give the panellists the time and then to get to some of the questions. So quickly, any plans to help breastfeeding groups with how they can reopen safely, as many mothers are really missing this peer support? Also, any funding for these groups?
Yeah, so we have developed guidance for these groups, but I won't lie, like we worked closely with our HPSC colleagues around this, and the safety of our groups, the safety of our parents and all that is absolute paramount. So we have guidance developed on how groups can, and meet, and that has been given to the Latch On and Friends of Breastfeeding. But in implementation of that, you have to be thinking about all of the guidance around kind of the size of the venue and kind of the social distancing elements with it. And our breastfeeding support groups are very, by their nature, they're meant to be social spaces, and bringing kind of like toddlers and the cup of tea is so important. So it isn't an easy task. That said, we need to strive to support mothers to meet on a face-to-face basis. So I'm not saying it's not impossible. The guidance can be used and adapted, and outdoor spaces should be encouraged, and where we have large facilities and social distancing is important, we should be encouraging small groups of mothers to meet, because at the end of the day, mothers' experience and their mental health and their social and emotional supports are key drivers, in terms of their health, and we have to protect mothers as much as we can in this time. So guidance is there. I won't say it's nice reading. It is very much based on the safety of everyone at current times, and yeah.
One more question. It's actually in relation to media portrayal. So one of the presentators, highlighted realistic views of breastfeeding. Is it only of breastfeeding? Is there a need for realistic views of parenting through media portrayal, school books, etc., long before antenatal classes? Care of a newborn can be challenging no matter how fed.
No matter what, yeah. And I think it was one of the quotes I put in our own press release this year, that having a baby is a life-changing experience, period, and then, we're on a very steep learning curve after that. So I suppose encouraging our HSE campaigns team, they base campaigns based on what parents' current experiences are. So all of the My Child parenting campaign messages that you will hear on the radio, I think there's about 5 or 6 of them going out this month. They are about kind of common questions and are aimed at realistic kind of experiences. And we very much in the My Child breastfeeding content, based on mindful of how content is based on the website. It's not like big large booklets or that, but it tries to get across about what normal newborn behaviors are like and what the early days are about, and trying to be as realistic as possible with people, and as much as you can antenatally, and then steep learning curve after that, but what to expect. And we spend a lot of time, I suppose, planning our social media posts, and we definitely target a lot of these kind of messages, and in planning our posts, to make sure that we're not giving unrealistic expectations about it, and kind of really talk to people about what those early days and those early few weeks, and kind of what kind of challenges to expect to prepare for them. Yeah.
Thanks very much, Laura. I'm going to pass you back on to Gillian.
Thanks, Denise, and thanks, Laura. And it's clear, there's been so much work done in the HSE in the breastfeeding space, and the My Child resources and Ask the Expert. They're really excellent resources for parents, for mothers and parents. So thanks for that update there. So we're just coming to an end here now. So just before we end, I apologize. I know there's been a lot of questions, and I know Denise has put a lot of work into just choosing a few questions, but apologies if we haven't got to your question. We're a bit over time already, so I think we'll just keep going now. Before bringing the webinar to a close, I'd like to sincerely thank all our speakers for taking the time out of their busy schedules in order to talk to us today. So thank you, in particular, Lord Mayor Hazel Chu, for coming along and sharing her experience with us today. I'm sure everyone will agree that the presentations were extremely interesting and thought-provoking. In addition to the speakers, we'd like to thank Justin, who's organised all the technical aspects of the webinar, and Dr. Denise O'Brien, Head of Midwifery, for managing the questions. We were delighted with the interest in the webinar and the number of people who've attended, and clearly just from the chat there I can see everyone's been really engaged with it. So thank you for coming along. We hope that today's presentations will encourage you to continue your invaluable work supporting breastfeeding mothers in Ireland. And we know you all do put so much time and effort into supporting mothers, so thank you for that.